Okay, everybody, welcome. My name is Christine Buckley with the Brain Aneurysm Foundation, and I'm thrilled that you are all joining this monthly webinar that we've been doing, keeping up with that pretty well. And we have a great guest with us today, Dr. Tjoumakaris, who's with Thomas Jefferson in Philadelphia. She's also part of our medical advisory board. She's a great surgeon. She's renowned in all she does with neurosurgery and the groups like AANS and CNS and all the things that she takes part of, and supporting her patients and her families in a very full way, not just treating them in the hospital, but follow-up care and doing things outside that regular care, outside the hospital, involved with, again, the associations and different research to make sure that her patients and all patients get the best care possible. So the subject for tonight's webinar is who is at risk and what is the best defense? But first, I'd like to introduce Dr. Tjoumakaris to say a few words, and then we'll start the Q&A that we have and go to some of the questions that you have all submitted. So, Doctor, I pass it to you.
Thank you, Christine. You're making me blush. I appreciate all your kind words. And I'm very proud to be a member of the Brain Aneurysm Foundation. It's an incredible organization supporting our patients, their families, and just navigating through a very challenging disease process, and the consequences, the sequelae of having a ruptured aneurysm. In brief, I am Dr. Stavropoula Tjoumakaris. I am a professor of neurosurgery and radiology at Thomas Jefferson University. And like Christine says, I specialize in cerebrovascular and endovascular, so anything relating to the blood vessels of the head and the entire nervous system. I'm very involved with organized neurosurgery, with our joint cerebrovascular section of the Congress and the American Association of Neurological Surgeons, and also our Society for Neurointerventional Surgery, Society for Vascular Interventional Neurology. There's a lot of societies that are joining and coalescing to contribute to caring for patients with ruptured aneurysm. So from a neurosurgery, radiology, and neurology side of things. So proud to be here today, and I'm ready to chat about aneurysms and patients at risk.
Awesome. Thank you so much. So the first question is, who is most at risk for a brain aneurysm, and what is the average age for someone to be diagnosed?
That's a great question, Christine. And the average age of diagnosis tends to be in the 50s. This is for aneurysms that either present with rupture, subarachnoid hemorrhage, or aneurysms that are found incidentally. Obviously, we always say that there's no age, there's no cutoff. We've treated patients in the pediatric population, and we've treated patients way into their 90s. So it's a disease that can afflict really a patient at all age, but it tends to be middle age for the diagnosis and management. Remember that we only see a subset of patients of aneurysms that either become symptomatic from the feared rupture, the subarachnoid hemorrhage, or others that are incidental findings, either because they're having headaches. Some may be related to aneurysms, others may not, or they could be getting an ENT workup for head and neck issues, and may be lucky enough to have an aneurysm detected incidentally. So we're just scratching the surface in terms of knowing the true incidence of cerebral aneurysms.
Excellent, thank you. Do we know why women are at a greater risk and why women of color are more likely to rupture?
Another good question. So we do know that most of the studies, some of the studies are from diagnostic angiography. There's some studies that are done in tens of thousands of patients, cadaveric studies. And all in all, they have found that women have a slightly higher predominance of aneurysms, on the average, perhaps anywhere between 1.3 times to sometimes 2 times, depending on the study, the ratio of their male counterparts. So there is a predisposition. Unfortunately, we haven't really figured out a genetic predisposition that makes women more susceptible. Some suggestions, again, this is not strong evidence, but some suggestions that women that harbor aneurysms later in life could be because of the lack of estrogen, that sometimes estrogen could potentially be protective from developing new aneurysms later in life. Obviously, a lot more studies need to be conducted and good national and international data to be pulled for all this. In terms of women of color to have a higher risk of rupture, I think it could be related to risk factors. So as we know, high blood pressure, high cholesterol, especially high blood pressure, could be linked to aneurysm rupture. And if in this patient population, we have a higher incidence, then potentially that could be a contributing factor. We know that different nationalities could have a higher incidence of subarachnoid hemorrhage, such as Japanese and some Finnish populations. And again, these are patient populations that we're studying very carefully to see if we can come up with a genetic predisposition that leads to aneurysm formation and rupture.
Great, thank you. Regarding family history, what should people be aware of in terms of screening for other family members, particularly children?
Great question. So familial aneurysm syndrome is defined as 2 or more first-degree relatives that have cerebral aneurysm. So if you have an aneurysm, doesn't necessarily mean that you should screen your family. Not necessarily. However, it's an MRA, which is a screening tool. It's a 5-minute study and could save your life, or your children's or your loved one's life. Another issue is, I think previous generations, we may not be capturing an aneurysm, or most significantly a ruptured aneurysm, because, you know, back 30, 40 years ago, they called a lot of strokes, right? And autopsies were a little less prevalent. Imaging was less prevalent. So I think we're missing some prior family history. So I always tell my patients, I err on the side of caution. You don't need to have 2 first-degree relatives to get a quick screening study, which is an MRA that can save your life. So if I had an aneurysm, I would definitely recommend my kids to get screened. But for familial aneurysm syndrome, the definition is 2 or more first-degree relatives. By then, if you do have that, absolutely, you need to screen all first-degree relatives with an MRA.
Okay, thank you. And, you know, related to that, because I think, you know, we do work on Capitol Hill, and the screening issue has come up a lot. And a lot of the people that we've met in the congressional offices have been very surprised that the recommendation, you know, kind of on paper is if there are 2 or more first-degree relatives. So do you think that there will be a point in time, like through these associations, that there might be a change in that if there's more data available to support it?
Absolutely. And I think we should move in, similar to getting a colonoscopy, right? Obviously not to the same rate every 5 or 10 years, but we should at least early in life get a screening MRA, especially in patients that have at least one family member with a cerebral aneurysm. I don't think we need to wait to have that second family member. It is a very quick study. There's no harm. It's a magnet. There's no radiation or any associated risks in getting that study. And I do appreciate all your work on the Hill. Yeah. And, you know, please keep it up. And we really need to move forward and push to make a change on this. Yeah,
thank you. So we get lots of calls of all kinds of things here at the foundation every week, but people often ask us what they can do to prevent the development of a brain aneurysm. So I want to know what you might recommend on that, if there are such things. And people always ask, like we had a call yesterday and someone wanted to know if they could go scuba diving, if they have an aneurysm that's being watched and followed, and people similarly ask that about flying as well. So just wanted to get your thoughts on those things.
Yeah, that's a great question. In terms of what they can do, in terms of incidence, if you have a connective tissue disorder such as Ehlers-Danlos malformation or Marfan, so you may have a higher risk of developing an aneurysm. Also, some other medical conditions such as polycystic kidney disease. If you or your family members have cysts in their kidneys, they can also be linked to aneurysm. So there's certain medical conditions that should raise a red flag for you to be screened and monitor. If you have an aneurysm, things you can do to prevent a rupture. Number one is smoking. If you are a smoker, you need to quit smoking. Smoking increases the risk of aneurysm growth, aneurysm rupture, and in women, there's an additive risk factor by almost threefold. So the best thing you can do is to eliminate smoking. Both primary and also secondhand smoke can contribute. And then other risk factors such as high blood pressure. If you have hypertension and you do have an aneurysm that's not indicated to be treated, then you need to keep it under tight control, because obviously the higher the blood pressure, the higher the potential risk. Similarly, some substance abuse, cocaine, for example, and any substances that are what we call sympathomimetic, raise the blood pressure. That can actually contribute, and we've had patients that come with ruptured aneurysms and AVMs with his substance abuse history. In terms of blood thinners, that's another common question, Christine. You probably get that a lot.
Yeah.
If a patient needs to be on blood thinners for the heart, let's say for an arrhythmia or something of that nature, having an aneurysm doesn't necessarily preclude that. So you need to have a close communication with the cardiologist or primary care, because it's not going to, the blood thinner is not going to elicit an aneurysm rupture, but you really need to keep a close eye on the blood pressure in that setting. Flying, very common question. There's really no strong evidence that the change in barometric pressure with airplanes will elicit a rupture. The only thing I do worry about with my patients is obviously if you're the destination, if you're in an area that's underserved, doesn't have good medical care, and happen to have a rupture, obviously, that could be a little more concerning in terms of transferring to a tertiary care center to be taken care of. So I have no issues with patients flying with unruptured aneurysms. Obviously, garden variety, we're not talking about the giant aneurysms where hemorrhage is imminent, they need to be treated immediately. Scuba diving, that's a tough one, Christine. And I think in some questions, sometimes we're asked questions where we may not really have medical knowledge, but if you're a scuba diver, I would, in all honesty, be worried if you go, if you're a professional scuba diver and you go really deep, because we're talking about profound changes in barometric pressure. And on that level, I would probably recommend just to, do very basic depths and not go to real deep areas. Again, no good evidence for that, but just using medical discretion, I think that's probably more high risk.
Thank you. So again, research is always a big topic. So what do you think are the greatest strides forward in research for both detection and treatment? And do you think that AI is going to have an important role going forward?
Absolutely. I think artificial intelligence are going to help us not only to pick up cerebral aneurysms from systemic workup, different findings that could be related based on the blood vessels of the rest of your body with brain aneurysms, but also picking up those high-risk features and help us with algorithms from thousands of patients. At what point do we need to worry? We have a lot of criteria and we have a lot of studies, but if we can make that automated and know at what point we need to worry about potential rupture in high-risk patients, I think that's where AI will be really, really beneficial. And then obviously treatment, robotics and artificial intelligence, I'm hoping will help us to treat patients in remote settings, in areas that are underserved, and also help us during the treatment by picking up, different maneuvers and different conditions that potentially can increase the risk of rupture. You can detect it with superhuman speeds that could be beneficial in how we manage patients and monitor and move forward.
Okay, thank you. Another question, how do you think we can better educate the public on the signs and symptoms? I mean, we struggle every day trying to do this, and we wonder how effective things are that we're doing, and there's just still seems to be a knowledge gap in the public for sure. So just wondering what your take on that may be.
I think, Christine, you and your group dedicating your life's work in educating the public is really commendable. We need more organizations like you nationwide. I know there's the B Foundation, there's a few. We need to increase awareness because the symptom of a cerebral aneurysm, either imminent rupture or rupture, is a very common symptom. One of the most common medical symptoms, and that's headache. And I can't tell you how many patients have had warning headaches that unfortunately either the patients or physicians don't heed the warning signs, and that could have, as we know, a catastrophic consequence. So what I tell patients is, and a lot of our patients have migraine headaches. Migraine to me is a diagnosis of exclusion. If you have a lifelong history of migraines and you have the typical migrainous pattern, either around your menstrual cycle, one-sided headache with, ocular findings, sometimes flashes of light. If you have the typical migraine headaches, I would still recommend you see a neurologist to confirm that that is the case. And that's your new baseline. You know what your daily headache is like. Aneurysmal headache is a different kind of headache. Things that make it different from other headaches is the acuity. It's described as a thunderclap, acute onset. This is not a lingering headache that progressively escalates. And the severity. If your daily headache is rated 5, 6 out of 10, this is a headache that, although I haven't experienced, our patients say it's a headache like no other. It's a profound 10 out of 10 headache. Oftentimes from increase in pressure after an aneurysm rupture, there's associated signs and symptoms of high pressure, which are nausea and vomiting. They're also red flags in association with a headache. And then meningeal signs. In other words, the aneurysms are in the meninges of the brain, and they're not inside the brain parenchyma, the meat of the brain, to put it in layman's terms, but they are in the infoldings of the brain. So the meninges can get irritated with the rupture, and sometimes patients can have light sensitivity and neck stiffness at the same time as a severe headache. If you experience any headache like that, or know of a friend or family who does, please call 911. We call that a sentinel headache, and that could be a warning headache or an aneurysm rupture headache. And really, every second counts. Time is of the essence. So we need to spread the type of headache that the patients need to be alarmed about. Most importantly, if there's a family history of brain aneurysms.
Thank you. And then we touched upon this a little bit, but do you think that there ever will be a screening protocol for brain aneurysms, at least for some subset of the population? And if so, when do you think we could maybe envision seeing that?
Yeah, I tell this to some of my patients. I would love that every baby is born with a screening MRA, because most of the times we're born with these aneurysms. They're less likely to develop later in life. Again, unless you have a problem with the building blocks of the arteries, the constituents, like some of the diseases I mentioned, the connective tissue disorders. So I would love to have screening very early. Who knows, maybe part of, an ultrasound of pregnancy, right, could also be a new detection, not necessarily an MRI, but a new detection tool to capture these aneurysms at birth. That would be most ideal. Otherwise, a screening MRA, I think, would be great. The sooner you do it, the better. The limiting factor in children is, being able to withstand being immobile in a magnet, so that becomes part of the issue. So perhaps in teenage or early adulthood would be a great range.
All right, excellent. So we have a lot of questions that we had submitted. Lynn, I don't know if you saw any in the chat that you want to address, or if we want to go off the questions submitted, we could go back and forth a bit.
The ones in the chat, I think, have been talked about. One was asking about flying. Can stroke cause an aneurysm to rupture? I am susceptible to TIAs.
Yeah, so two completely different processes. TIA is a mini stroke. It's a warning of potentially a future stroke, and it's the brain not receiving enough blood supply. So that's the complete opposite from a cerebral aneurysm, which is a blister on the blood vessel wall, and the brain actually receiving too much blood if that blister ruptures. So two completely different processes. They can both lead to brain injury, but having TIAs needs medical attention to find the source, whether it's the heart or the carotid arteries. but does not predispose you to have a cerebral aneurysm.
That was it in the ones in the chat right now.
Okay, some people have been asking, what are the chances of having more than one aneurysm, particularly if you have one treated and then another one coming up after the fact? I know some people, when they get diagnosed, they know they have more than one, but they want to know what's the chance of getting another after you have one treated.
Great question, Christine. So typically having an aneurysm has a risk of you having another aneurysm. Sometimes we call them mirror aneurysm if it's the same exact aneurysm on the other side of the head. It can be, depending on the literature, anywhere from 3-4% up to 10% higher likelihood. Again, you're typically born with them unless you have one of those genetic predisposing conditions that we discussed. You are most likely to remain with the same number of aneurysms the rest of your life. Other reasons where patients develop pretty aggressively and pretty quickly brain aneurysms if they have infections in their bloodstream. These are called mycotic infectious aneurysms. Obviously, they need to be very closely monitored, and the patient needs to be treated for the infection. But other than that, it's less common that they will develop one later in life. What I tell my patients is if we're monitoring, let's say 1 or 2 aneurysms, every time they get a screening MRA, let's say on an annual basis, it will screen the entire vasculature. And if they are one of the small subset of patients that develop another one later in life, it will get captured. I would put that in the order of 5% or less. So it's not a very high likelihood.
Okay. And then back to screening again, people are asking, there's different variations of it, but there's someone that has like a family history, 2 generations of aneurysms, and they have a couple children. So what age would you start scanning them, and how often would it continue throughout their life?
Great question, Christine. And again, another one that, although there's not great literature to support this, I would probably do once they're 18 years of age or older. And if because they're still young and in their formative years, I would probably repeat it every 5 years to be safe with a negative MRA, at the very least every 10 years.
Okay, great. We had a prior webinar, I think the last one was about like waiting and watching. So someone is asking, is the size of the aneurysm one of the main things that determines what type of treatment plan that you have? And also, is it something that you can treat, or is it something that you watch? So what are the biggest factors in treating or waiting?
$1 million question. So there's a lot of great studies that we have that give us some guidance and some basic principles. Size is absolutely important. The larger the aneurysm, the higher the risk of rupture. And obviously, once we go into really extremes of size, 25 millimeters or greater, we call those giant aneurysms that have a really high morbidity and mortality rate, unfortunately, with or without treatment. So size is important. Location is important. Having an aneurysm in the back of the brain, the posterior circulation, and that's the vertebral arteries and the basilar artery, have a higher risk of rupture. So they tend to be a little more dangerous, and we have a lower threshold to treat in that location than in the front of the brain, the carotid arteries. And then we also looked at the morphology of the aneurysm. If you have a small, smooth domed aneurysm, it's a little less concerning than an aneurysm that has, for example, a sister dome, an excrescence, we call it. In other words, a blister on top of a blister. And sometimes some of our patients require better imaging modality, whether that's a special CAT scan or a catheter angiogram, to be able to discern those details. So those are the main 3 things that we look at. When it comes to risk factors, we look at age. The younger the patient, we have many years to worry about potential rupture, high blood pressure, and smoking. Those are risk factors that we actually incorporate in the decision making. And also, if we are going to recommend treatment, what is the best treatment option?
Okay, someone is asking if you can speak a little bit about a basal or fusiform aneurysm and how that differs from others.
So fusiform aneurysm is not an aneurysm in the sense of the word where there's a blister. The word aneurysm is Greek, so I can tell you that by definition, it's correct. It just means widening of the vessel. So fusiform is exactly that. It means that the blood vessel is wider than normal. And sometimes they're often found in the basilar artery. And sometimes they can be so profound where patients can have mass effect from the basilar artery itself becoming wider. We had a journal club just this past year with other European and colleagues from the United States, how to best treat these aneurysms, because they're not your garden variety aneurysms. And they have a much higher risk of not just rupture, but most importantly of ischemia, of stroke, and also of the aneurysms growing in a way that it can behave like a tumor and have mass effect in critical parts of the brain. Treatment for those aneurysms either requires, if they're indicated to be treated, oftentimes they're better left untreated. But if they really become symptomatic and absolutely need treatment, it's a very specific, careful protocol that requires a lot of blood thinners, because the basilar artery is known to have these perforators, and perforator arteries are hair-thin arteries that provide blood supply to the most critical part of the brainstem that controls all motor, all sensory, and all the automatic functions. So very specific protocol on pretty significant blood thinners, and some of them can be treated with flow diversion, putting a special stent within the basilar artery, or potentially microsurgical reconstruction, which is even more challenging because the artery in itself has disease. But oftentimes these are best left untreated and potentially treated just medically, because the risk of the intervention often is really high, and they could have pretty significant consequences in that area.
Okay, and to follow up on that, someone just asked in the chat, why would you not treat an aneurysm?
We would not treat an aneurysm if it's really small. Small aneurysms can have a less than 1% risk of hemorrhage. If the aneurysm is not inside the brain, remember the carotid artery goes from the heart through the neck, in the skull, and then ultimately through the dura in the brain. So there's a transition where the artery is inside the skull but not in the brain yet. And those aneurysms can be monitored because we're not worrying about a rupture in these cases. So benign small aneurysms in benign locations can absolutely be safely monitored.
Great. And this question of the ages is, has there been a link made between COVID and brain aneurysms?
That's a great question. We have certainly seen patients that came in with subarachnoid hemorrhages. In general, both ischemia, lack of blood supply, and hemorrhage in the brain, even in younger patients, younger than the 50s, were noted during the pandemic era, and not necessarily a direct link of aneurysms, but we did have a bit of a spike with intracranial hemorrhage and ischemia. Obviously, we're still investigating if how that affected our COVID patients, and hopefully we're a much better place now than we were a few years ago.
Yeah, absolutely. Another question that we get a lot is there a relationship between brain aneurysms and aneurysms in other parts of the body, like the stomach or aortic aneurysms?
Yeah, so that's a very common question. Garden variety aortic aneurysms are known as AAA, the aortic abdominal aneurysm. They're not linked. Those can be hereditary. We have one of them, or your family does. You can be screened with a quick ultrasound, and high blood pressure and smoking are also risk factors, but typically in those two, they're not linked. There are, again, connective tissue disorders that could predispose you to aneurysms, and really multiple areas of your body. And again, for those, you need to see a rheumatologist and follow up, potentially get screening everywhere in your body. For example, we mentioned Ehlers-Danlos, Marfan's, fibromuscular dysplasia. Those are some conditions that you should be screened.
And someone is asking, they've been treated for a rupture, but they live somewhere now where there's not easy access for follow-up care. Is it important to get that follow-up care? I don't know if they were clipped or coiled or whatever, but they're just saying they're kind of in a more rural area and it's hard to get that care. And should they get follow-up?
Absolutely, and I'm happy to see them via telemedicine.
Oh, there we go. Nice.
In other words, telemedicine has now opened up the barriers and patients can access at least basic care in terms of a consultation and referral if they need follow-up. Would recommend at least that they see once a specialist. If it's coiling, typically we do a 6-month post-coiling angiogram and MRA, and then if things are stable every year after that, because coiling we need to watch out for any recurrence. If it's microsurgical clipping and the aneurysm is 100% secure, they tend to be cured, but obviously they still need to see a physician in terms of getting long-term follow-up. In our patient stage, we do a 5-year post-clipping angiogram just to ensure that the treated area remains 100% occluded and there's no de novo, in other words, new aneurysm. So more frequent follow-up in the endovascular treated patients and still follow up even in the open microsurgical clip patients. So I would recommend for them to at least see a specialist once and have a plan.
Excellent. Someone wants to know what to do if they receive 2 different opinions on treatment.
I would go for a third.
Yeah.
In other words, you just have to make sure that you're educated into some important questions I would ask. What is my risk of rupture? And what is the risk of treatment? And you need to weigh risk and benefit. We always want to make a recommendation to improve a patient's outcome. So risk to benefit ratio needs to be favorable for the patient. And again, there's a lot of the treatment option is also, it can vary from physician to physician. So I would ensure that I'm hoping you'll get an unbiased opinion. So I would recommend another recommendation. And ultimately, you need to trust your physician. So I cannot emphasize enough to establish the rapport and the healing patient-physician relationship. Because if you trust your physician and you trust that they will do the right thing for you and your family and your aneurysm, I think that's a win-win situation. So if they haven't found the rapport, I will keep on looking until they get there.
Excellent. Something similar. What do you think are important factors when someone is choosing a doctor in a facility? Like, say they have options from where they live. If there's 3 to 5 places they could go, what are important factors when making that decision?
Yes, I think I just mentioned one. I want to make sure that my patient feels comfortable with the care, that the patient and their family, the care is tailored to their needs. And we don't make cookie cutter responses, how to treat an aneurysm in this age group. 2 50-year-olds could have 2 completely different risks for surgery, 2 completely different risk factors, medical conditions. So just make sure that you're getting that individual care and a plan that is really conformed to your specifics. I want to have the whole family and the patient incorporated into the decision-making process. It should be a dynamic dialogue as opposed to authoritative. Know the data, feel comfortable with your physician. The team is very important, right? You want to go to a facility that they treat a lot of these, not a facility ideally that they only do 5 or 10 of these a year, because it does make a difference in terms of outcomes. I actually contributed to a phenomenal paper we finished and was published in Stroke, updated guidelines for management of subarachnoid hemorrhage and treatment of ruptured aneurysms from the American Heart Association. Every 10 years, we have new guidelines. And we did find that practices that are busier in terms of larger practices can have better outcomes in terms of patients with ruptured aneurysms, especially the ones that come in a very critical state. So all those in my mind make a huge difference in terms of making a selection. And trust your instinct. If you're not getting that gut feeling that you trust your physician and the team, I would make sure it's of paramount importance to build that healing relationship between the patient and your physicians. Not just in neurosurgery, really primary care, I think all across disciplines.
All right, thank you. Something else is people are curious if having a brain aneurysm earlier in life makes you more susceptible to having dementia down the road?
Great question. Just having a brain aneurysm, no, but having a rupture, potentially, rupture is a form of brain injury. Let's not forget the most common form of dementia is we call that multi-infarct dementia, patients that have multiple repeated small strokes. If you think of aneurysm rupture as a form of brain injury, then for sure it can unfortunately predispose you to some memory loss, some neurocognitive deficits, and potentially, expedite the natural process of dementia. Because I think dementia in the aging can be part of the normal aging process, potentially could expedite it. Not always, but there is a chance.
All right, thank you. Now I'm just kind of checking the chat again as we're winding up here. Someone said they had an endoscopic stent 5 years ago at the age of 35. Are there any safety precautions they can take as they age? They're not a smoker and any other high-risk behavior, but they travel a lot.
Yeah, really, I'm sure they meant endovascular stent. I would urge them to make sure they have follow-up with their physician and the aneurysm is well taken care of, and get frequent screening, routine surveillance MRAs. Like we talked about earlier, traveling is not going to make the aneurysm rupture, but I would feel much safer to travel, especially if you go to these exotic places where care could be, a little more challenging, medical access to care, just to make sure your aneurysm is secure before you travel like that.
Okay, and are MCA area aneurysms a higher or lower risk?
Commonly seen, but not as high risk of incidence as other areas such as the anterior communicating and the posterior communicating. They tend to be higher incidence, so not as high as those two that I mentioned. In terms of rupture, it is in the part of the carotid artery. It's the distal bifurcation of the carotid artery. Therefore, less propensity to rupture than the posterior circulation, basilar, vertebral arteries, etc.
Okay, thank you. Someone wants to know, how long can someone live with an unruptured brain aneurysm?
The rest of their lives, hopefully, with close monitoring and making the right decision when to treat or not treat. This could be like a benign thyroid nodule that you get your studies once a year just to ensure that there's no growth. Patient's symptoms are closely monitored for any of those concerning headaches. Controlling the risk factors such as smoking, eliminating smoking, controlling blood pressure. Those are all important for hopefully a lifelong diagnosis with no rupture.
Excellent. I think at this point, we've kind of covered everything in terms of questions relating to the topic. And as everyone knows, this is being recorded and we'll have the recording out hopefully by the end of the week, if not early next week. And I just want to again thank everybody for joining, particularly Dr. Stavropoula Tjoumakaris for taking time out of her busy schedule to share her knowledge with her and with us, I should say. And I have one favor to ask you. Can you send me that recent article in Stroke, because I saw it and I had a link that didn't get me to it?
Absolutely, happy to do it.
Yeah, because I'd love to see that. And you're getting a lot of props in the comments as well, which I think you are noticed by new people and people that you have treated.
I see some of my patients there. I salute them all, and they're my inspiration. As are you, Christine. I cannot thank you, Lynn, and everybody in your group for all your tremendous effort in increasing awareness and helping patients and families. It's so important, and I thank you for it.
Oh, thank you so much.
Thank
Have
you.
a great night, everyone. Take care.